I'd like to invite Dr. Resmi Bhaskar. She is a consultant pediatric ophthalmologist from Chaitanya Eye Hospital, Trivandrum. She'll be talking on the right time when to do the strabismus, whether you have to do it early or late.
Thank you, Dr. Soumya, for giving me this opportunity. The right time for squint surgery, early or late? Actually, there is no right time, there is just time what you choose to do with it. There are certain factors determining the timing of surgery. We can classify them as ocular factors or general factors. They include the age of presentation. That is, sometimes they will come to you at 4 months of age, and some children will come to you only at 4 years of age after starting school and all. The type of squint, whether convergent or divergent, whether it is constant or intermittent. Angle of deviation, whether it is small or large. Duration of squinting, refractive error if any, and presence of amblyopia. And the general factors include how cooperative a child is for evaluation, developmental status and birth history of a child, systemic condition like cerebral palsy, Down syndrome or any other anomalies associated, expertise of surgeon, whether they are capable enough of doing surgery in very young child, and safety factors associated with general anesthesia as Dr. Soumya has detailed, and pediatric postoperative and ICU care. Because most of us will be working in an eye hospital, and it will be scenario will be different in case of a multi-specialty hospital. Each child is unique, and so is each case. So we'll see a few cases. Let us assume the case of an essential infantile esotropia. These are few cases that we operated the earliest. Let us see with a 4-month-old child coming with squinting, large angle squint with cross fixation, normal fundus and refraction. So what is the earliest possible age that surgery can be done for an infantile esotropia, and does the patient benefit from early surgery? Let's see what studies have to say. The researchers say that even in 1990, it was studied that the diagnosis of essential infantile esotropia can be made even up from 4 months of age. When the average axil length is more than 19 millimeters, that is in around at 4 months, that is sufficient for surgery. And Dr. Kenneth Wright has also established that high-grade stereo acuity can be attained by doing surgery at an early age. He himself has did surgery for his son who had an esotropia at a very early age, and he says that he has very good stereopsis and is a pilot now. And the study published in BJ also says that early surgery is beneficial to achieve binocular function, but the stable deviation measurement has to be done. In IJO, a meta-analysis was published regarding the timing of surgery in essential infantile esotropia, and they say that the critical period of sensory and motor development is 4 to 6 months of life. And they say that the children who underwent surgery in less than 7 months had a better stereopsis than those who underwent before 2 years of age. And the asymmetry in motion VEP was also more when the surgery was done in 11 to 18 months, and it was almost same as that of normal when the surgery was done less than 11 months. And abnormal and asymmetric OKN response was seen in children who underwent surgery in 11 to 18 months, and it was almost comparable to normal when the surgery was done less than 11 months of age. This is a case of essential infantile esotropia. So who are the children who will benefit by early surgery? When the presence or persistence of esotropia between 10 weeks and 6 months, constant angle deviation of more than 40 prism diopters on 2 examination 2 to 4 weeks apart. There is no refractive error, that is less than 3 diopters, and absence of the following conditions: gestational age less than 34, birth weight less than 1.5, no history of any ventilator treatment, no history of any meningitis or developmental delay, no non-paralytic or concomitant squint, and manifest nystagmus. There should not be any manifest nystagmus, prior eye surgery, or presence of any structural ocular anomalies. Regarding the anesthesia concern, as per the gas study, they report that around 45 minutes to 1 hour exposure of GA has no adverse long-term effect in children, and the benefits of early correction outweighs the risk of anesthesia. So what are the advantages of doing an early surgery in case of infantile esotropia? Better stereopsis and binocularity, reduced incidence of postoperative DVD and inferior oblique overaction, minimize the delay in sensory motor and motor development, and improve psychosocial and parental bonding. And the disadvantage is accurate estimation is difficult, and possibility of development of accommodative esotropia as sequelae. Coming to the late surgery advantage, you get an accurate measurement, and correction of the vertical misalignment can also be done in the same sitting, and the possibility of correcting amblyopia is also successful. And the disadvantage is increased incidence and severity of DVD, and poorer gross and fine stereopsis and binocular vision. These are the inference that they gave after that meta-analysis. Coming to the next entity, which is a congenital exotropia, it is rarer than the infantile esotropia, onset before 6 months and large angle deviation. As per the study published in 28, the early versus late surgery for infantile exotropia, they say that the results of older age surgery, that is 2 to 4, has outcome comparable to the younger age. And they also say recommend the surgery after 1 year because their younger age was associated with reoperation and consecutive esotropia. Coming to the intermittent divergent squint that we see most often in our OP, the relationship between age and surgical results is always controversial. Most of them have good binocularity, but if they are overcorrected, they will lead to amblyopia. So let's see what the studies have they say. They say that the better motor alignment and sensory outcome are done when surgery is done less than 7 years. Younger age at onset and surgery were risk for developing recurrence in the larger case series as told by Kim et al. In International Journal of Ophthalmology, a study was published regarding the surgery at early age versus late. They found that a better long-term follow-up outcome when patients' surgery was done when younger than 4 years old. In a study in JAPOS, which was published in 2022, they compared the motor and sensory outcome. And when the surgery was done less than 5 years of age, they had a outcome of 84% success rate, and overcorrection was also 3% only. When the surgery was done above 4 years, they had a 68% outcome and a 8% of overcorrection. The conclusion, they found that the surgery at younger age was associated with higher success rate, but the risk of overcorrection can be minimized if you reduce the surgical dose. The indications we all know, it is increasing angle of deviation, deteriorating control, decrease in stereopsis and distance on ear, and motor alignment. Advantages of early surgery for intermittent divergent squint is greater chance of bifoveal fusion, superior BSV, less chance of being constant, and better long-term results. While disadvantage is higher chance of overcorrection and amblyopia, and age affect the surgical dose effect response. The late surgery advantage, accurate evaluation is possible. Most of the cases they have intermittent divergence, have a good stereopsis and binocularity, and so the chances of post-op overcorrection and amblyopia will be less if you correct lately. But the disadvantage is no restoration of binocularity, only motor alignment you will be able to achieve. In acute comitant esotropia and in case of paralytic squints, we all know that if the angles are stable for 6 months and if there are no treatable causes, the surgery can be done within from 6 months of age. And in case of congenital restrictive squints like Brown syndrome or Duane's, depending upon whether they are amblyopic and what is their alignment, how is their abnormal head posture, depending upon that, early surgery can be done. Better late than never. So any patient coming to you at the age of 50, 60 or 70, squint is a reconstructive and recreative surgery that improves the quality and clarity of vision. It's not a cosmetic surgery, and it's a right of each person to look straight. So take home message, in essential infantile esotropia, you can do surgery even as early as 6 months of age if other conditions are playing. An intermittent divergent squint, the ideal age is 4 to 7, acquired squint after 6 months, and no upper age limit. Thank you.
Thank you, Dr. Resmi, for that wonderful